This
Shepherd.
conference
I'm
will now.
Virginia Nurses Association and will be facilitating today's discussion. Currently, we have placed everyone's line on mute and will unmute our speakers. I'd like to thank you in advance for your patience as we are all working through different remote locations in order to bring this event to you today. I would also like to ask you individually to mute your phones and turn off all webcams if you are not a presenter. This is in the event we have technical issues and have to centrally unmute the lines. I would like now to introduce you to our guest, Senator Tim Kaine, Governor Ralph Northam, Jeanne Giselle, Director of the Public Health Nursing at the Virginia Department of Health. Welcome to you all. Thank you for joining us today, as we realize this is an extremely busy time for each of you, so we really appreciate you carving out the time of your busy schedules to be here today. So a little bit about the format before we get started. This event is being recorded. We will post and share the recordings so all nurses can benefit from it. Our guests will share information and then take questions. The questions have been compiled from more than 300 we received from participants to cover the concerns mentioned most frequently. VNA staff is working to provide answers to other questions as well, and these will be posted on the COVID-19 resource page on our website at www.virginianurses.com. We will have our chat open for questions in case we have a few extra minutes at the conclusion of all presentations. And the VNA is also working on scheduling another COVID-19 event, including an upcoming Facebook Live event to discuss PPE. So now I'm going to turn the discussion over to Senator Tim Kaine, who will be discussing stimulus package and the impact on healthcare. Senator Kaine.
Hey, well, thank you so much. And I'm having a little bit of a technical challenge, so I think folks can hear me, but the camera function isn't working, but I sound better than I look anyway. So let me just focus on this bill. And I want to appreciate the nurses for pulling this call together, and particularly thank Governor Northam for being on his team. The tradition would be that the governor would go first because there's only one governor while there's two senators. But I do think this COVID-3 bill that we passed and was signed into law over the weekend is a pretty big one. And so let me just summarize it for a few minutes, and then I'm here for questions, and then I'm going to stay on the call with my phone muted to hear the discussion with the governor as well. So I really do appreciate you frontliners who are providing care to Virginians at a time of increased healthcare challenges, but also there's just dramatic anxieties that people have, and our nurses are some of our best in terms of reducing people's anxiety. So thank you for that. And I was really appreciative of the chance to be on the phone with many of you last week. Let me jump in. We have passed 3 bills in 3 weeks dealing with the coronavirus challenge in Congress, showing a degree of bipartisanship when the stakes are high. The first was an $8 billion supplemental appropriations bill, first week in March. The second was a multi-billion-dollar bill to expand paid sick leave and unemployment insurance. But the last bill that we passed last Thursday morning in the Senate and then was passed in the House and signed by the president was by far the biggest. It won't be the last bill we'll do, but it will be the biggest. $2.2 trillion to try to protect the American economy. There were 5 pillars of this bill: aid to individuals, aid to small businesses, aid to large businesses and industry sectors, aid to state and local governments, and aid to hospitals and our healthcare system. And I want to focus on that 5th pillar. What did we do in the 5th pillar? And then future asks, then I'll open it up for questions or follow the lead of the moderator. The 5th pillar to shore up the healthcare system was as follows: $100 billion for hospitals, community health centers, and other entities. And these grants are used to cover unreimbursed healthcare-related expenses or lost revenues attributable to the public health emergency resulting from the coronavirus. And this fund can help with building or retrofitting new ICUs, increase staffing or training, personal protective equipment, building of temporary structures, or making up for lost revenues due to canceled surgeries and other uses of funds. That's $100 billion. $1 billion to the DoD for using the Defense Production Act. That funding will allow the DoD to invest in manufacturing capabilities key to increasing the production rate of PPE and other critical medical equipment. $16 billion to refill the strategic national stockpile for critical medical supplies to try to meet this incredible demand. $4.3 billion to the CDC to support federal, state, and local public health agencies. Reauthorization and updating of nursing workforce training programs. This is Title VIII of the Public Health Services Act. The programs support the development of a robust nursing workforce critical to responding to COVID-19 and future public health emergencies. Allowing nurse practitioners and clinical nurse specialists to order home health services for Medicare beneficiaries, an expansion of what was allowed under Medicare previously. Establishing a ready reserve corps to ensure that the nation has enough trained doctors and nurses. Temporarily lift the Medicare sequester, which reduces payments to providers by 2%, and lifting that sequester, which was to go into effect from May 1, at least through December 31st of 2020. Increasing payments that would otherwise be made to a hospital by Medicare for treating a patient admitted with COVID-19. The traditional reimbursement rate would be increased by 20% for any COVID-19 patient. Qualifying hospitals, and particularly those in rural areas, can get accelerated Medicare payments. And then finally, a provision of $3.5 billion to states to increase funding for the Child Care Development Block Grant. So that is what's in this fifth pillar, specifically for the nation's healthcare institutions and providers. Two asks going forward, and then I'll stop. One, when you pass three big bills in 3 weeks under the kind of challenges we were under, and particularly trying to do it remotely where we couldn't all be in the same room as we were working on the third bill because of senators and spouses and staff members getting sick, we're going to need to do two things. One, really focus on implementation. In the weeks ahead, we need to get the dollars out the door and see that they're being used for what they are supposed to be used for. And we really want to hear from you, our healthcare providers, the Virginia Nurses Association, about implementation glitches. So if you guys or the governor's team or others see that, the checks aren't arriving, hospitals aren't being helped, the stockpile resources are not sufficient for the states, we need to know about these, because some of the implementation issues we can fix through vigorous congressional oversight or reaching out to the administration. We can fix them. So we want to hear about your implementation challenges. My staffer, who is my chief health advisor, Katie Wright, is on this call. She or my chief of staff, Mike Henry, or my chief legislative policy guy, Nick Barbash, were all available if you see implementation issues that we need to work on. Second, there will be more COVID-19 legislation. Again, as we look at these three bills, we'll see gaps, we'll see omissions, we'll see details that we got wrong and need to repair. We'll also see some longer term questions. Do we have the right reimbursement philosophy around telehealth visits, which are more necessary for people who are far away from medical care and more necessary during a pandemic as people are worried about not being exposed to viruses. So we're going to be looking at longer term issues too. So the second ask would be, knowing that there will be future legislation, if you see items that should be included in that legislation, let us know about those too, because we will want to be responsive to that. So that's enough for my presentation. Again, 5 big pillars to this last bill, but the aid to our healthcare network might be the most important. We want to work with you on implementation. We want to work with you on the next pieces of legislation, and I'm really happy to be on this call today. And I'll go back to mute, except as I need to talk to respond to questions. Thanks so much.
Thank you, Senator Kaine. We appreciate that. Do have a few questions for you. Is the federal government using the Defense Production Act to produce PPE and ventilators?
Finally, the answer to that is yes. The president has authorized under his presidential power, and we included $1 billion specifically for this. The president has authorized and ordered particular producers to start producing ventilators and other equipment. So there's $1 billion in this bill for that. But the test is not what we're producing. The test is what our healthcare institutions are receiving. Bluntly, and when I first spoke to the governor about this, I sort of apologized. At the national level, the federal government was 6 to 8 weeks behind where we should have been compared to other nations. The U.S. and South Korea had their first diagnosed case the same day, but we were slower out of the blocks in both producing testing, but also testing materials, but also in putting the testing protocols in place and producing PPE, ventilators, and other critical equipment. The bill has funding for it. The president has authorized use of the DPA, and the DoD is moving out to do it. But the real test will be not what we put in the budget or say we're producing. The real test will be what you're getting, and we need to stay in touch with our healthcare institutions about that.
Thank you. Also, have we looked at other countries such as South Korea and what they've done to be successful in managing this crisis? And if so, are we adopting any of these strategies?
Bluntly, there is going to be quite an after assessment of why the U.S. was 6 to 8 weeks behind. I have been making that point on the floor of the Senate in speeches, and both the New York Times and The Guardian published fairly extensive stories this week about the U.S. was 6 to 8 weeks behind. I do think South Korea and Australia are two really good comparison points. China and Singapore have done some things, but those are, authoritarian nations, more or less benign, but that aren't necessarily the best example of what you can do in a sort of Western democracy. But South Korea and Australia are very good examples. South Korea had the first diagnosed case the same day as the U.S. had the first diagnosed case. But what South Korea did was immediately order mass production of tests using the WHO open source test protocol, mass testing of their population, contact tracing and quarantining of those who tested positive. And South Korea ordered its industries to begin producing testing and other relevant equipment. The U.S. didn't do those things. And I bluntly believe that when we get to the bottom of why, one of the reasons we lost 6 to 8 weeks is because at the very top from the president, there was a message that said this was not going to be a problem, that it was there were 4 or 5 cases, that they were going to be over soon, that this was not going to affect the United States, that it was blown out of proportion by Democrats, blown out of proportion by the media. The message from the person who has the loudest microphone in the United States, probably the loudest microphone in the world, was completely counter to the science, including the science that was being presented to the president by really talented people like Dr. Fauci and others at the NIH. You combine that with a set of steps that had undermined the public health sort of infrastructure, removing the staff that we had on the ground in China that were embedded in the Chinese Health Organization to help us be ahead of pandemics, eliminating the pandemic office in the National Security Council, continuously submitting budgets calling for reductions in public health spending. There's going to be a lot of reasons for why we were 6 to 8 weeks out of the block. The experience of South Korea and Australia will be relevant to that. The good news is America has been here before. World War II, we were very slow out of the blocks to respond to challenges. But the good news is when America comes out of the starting blocks, we can achieve a momentum unlike anybody in the world. And I do believe we are now focused and producing. But again, the test of that will be what you all tell us, what the governor tells us, and what our healthcare institutions tell us in terms of whether the resources we're providing are actually getting to the people who need them to do the important work.
Absolutely. So what type of benefits are being discussed, if any, for nurses and other healthcare workers who become exposed and may require long-term care as a result of treating COVID-19 patients?
That's a very good question, and I'm going to take that back, and Katie will too. I mean, obviously, we are. Give you an example. In the enhanced child care development block grant funding, we have waived income eligibility thresholds so that the child care providers who serve healthcare sector employees who are deemed essential can do that even if the income levels of those employees are higher. So there's an example of a financial benefit that was included in COVID-3 that was specifically targeted to our frontline healthcare workers to make sure that they could have access to childcare even if their income would not normally entitle them to take advantage of these programs. So between that and some of the retraining, the reauthorization and updating of the nurse workforce training programs, we tried to put some specific provisions in the COVID-3 bill to be responsible to the needs of public health workers. The question that you asked was a particular one. Are there benefits that are particularly to be focused on healthcare workers who get sick? We have an awful lot of benefits for hospitals who are treating COVID-19 payments, enhanced Medicare match, et cetera. The strategy, the question of are there specific benefits for those who get sick? I do not know whether there were specific UI or other financial benefits for healthcare workers who get sick in COVID-3. And instead, we were trying to target programs like childcare, et cetera, or workforce retraining specifically at healthcare workers rather than other kinds of workers to make sure that they get a priority right now. But if this is an issue, and it's going to be an issue, that will be one of the kinds of things that we'll have to look at in either the next bill or in implementing the COVID-3 bill.
Okay. We thank you for your time, Senator Kaine, and for answering those questions. And we're going to go ahead and move on to Governor Ralph Northam.
And I'm going to stay on the phone to listen and mute my phone. So.
Good morning. And first of all, Senator Kaine, thank you so much for taking time. I know you have a very busy schedule. Just thank you for your leadership and everything that you and Senator Warner and all of our other congressmen have done in Washington through the CARES Act and your other relief bills. We thank you, and we're in uncharted waters. So thank you for your leadership. To the nurses that are on the call, thank you. I will reiterate some of what Senator Kaine said, that you are the heroes. You are the ones on the front lines. You are the ones that are risking your lives and your family's health every day to do the job that you do. I have worked alongside of you for many years, and not only have you saved me over the years, but you've saved and touched so many lives. So thank you. And my message to all of you would be to make sure that your health and your safety is number one priority. I know we always worry about others, but we need you to stay healthy, and we need your families to stay healthy, because you are literally on the front line. So keep that in mind. And I know we all have situations in our lives and in our households, but take care of yourselves. We need you more than ever. So thanks for all that you all do. I remind people every day that we are in uncharted waters. For the last 4 or 5 weeks, our lives have literally been turned upside down. And so I realize that, and we are doing everything that we can to keep Virginians safe, and also to provide Virginians with updated and accurate information. We are in the middle of a tremendous health crisis. As I describe it, we are fighting a biological war. And we also are in the middle of an economic crisis. And my priority, and what I will continue to focus on, is to get this health crisis behind us. The sooner that we can do that, the sooner our economy will bounce back. There are a lot of moving parts on our plate right now, but just to talk about a couple approaches that we're taking. The first is containing this virus, doing everything that we can to minimize the spread. And as you know, we have taken a number of aggressive measures. And for the most part, I think that they're working, but not everybody is paying attention. And so at 2 o'clock today, I'll be making an additional announcement in addition to our executive order, regarding staying at home to make sure that that message is getting out to all Virginians. One of the things, and Senator Kaine alluded to this, that we're a little bit behind the curve in containing this because we were late in the game. And one of our largest challenges right now, and I know this is pertinent to what you all are doing every day, is our ability to test. And while the testing improves every day, the turnaround times can be at best from 2 to 3 days through our state lab to, I hear now, 7 to 10 days in some cases through working with our private labs, Quest, LabCorp, and others. UVA, VCU, some of the healthcare systems are now coming online with their testing, in-house testing. Also to have an antibody test, and I know that's kind of getting into the weeds a little bit, but that will help to see who has been exposed and who is safe to return to work. All of those things will be very important as we move forward, but the lack of being able to have a turnaround time and know who's at risk. For example, if a nurse has symptoms and we do a test and say, well, for 7 days or whatever, you're in quarantine, that takes away from our staff, and so we're working on that on a daily basis. As I said earlier, a lot of people are listening. They're abiding by our guidelines for social distancing, hand washing, those types of things. But unfortunately, I saw reports this weekend on some of our beaches and in some of our parks where people just aren't adhering. So we're going to have to clamp down some on that, and I plan on making that announcement at 2 o'clock this afternoon. I think what's probably most pertinent to your group is how we mitigate this, how we make sure that our healthcare system is able to take care of those individuals that are coming into our hospitals, and how we keep our healthcare providers safe at the same time. And certainly PPE has been a major challenge. We are working with different vendors. It's improving every day, but we've still got a lot of work to do. And just so you know, just to kind of put it in perspective, what we're doing is we're competing with other countries right now. We're competing with other states. Healthcare systems are competing with each other, competing with us in Richmond. And without a national program, without direction from the national level, it has been difficult. And I don't want to dwell on that, but I think you all understand that situation. Staffing is an issue now and will be even more of an issue if more patients are coming into our hospitals. As you know, we have the Medical Reserve Corps, and I just can't thank all the people across Virginia that have really stepped up to want to be part of the solution. And we have an organized approach as how we're handling and dealing with volunteers if we need to train them up, working with our community colleges. So that is moving forward nicely, but staffing no doubt is going to be an issue. And then finally, the bed space. And I just wanted to maybe clarify a little bit of that, and then I'll take your questions. We talk about alternative spaces and increasing our capacity for beds, and a lot of work has been done by our Corps of Engineers and FEMA. And we have looked at sites across Virginia in different regions. And the question is, if you have, let's say, an alternative site or a space, who's going to staff it? Who's going to be the administrators? And so the way we're looking at moving forward with that is to let our existing healthcare systems expand into those spaces, because the military and the National Guard, they can help out, but they're not really in a place where they can provide the staffing. So that's kind of the model that we'll use as we move forward. Obviously, the number of ventilators we have, and there's some very innovative approaches that we're using to maybe putting more than one person on a ventilator at a time. So a lot of good things are happening there, but certainly how we can make sure that our hospitals and our healthcare systems are up and ready to take care of the increased volume is something that we're spending a lot of effort on. And then one last thing I'll say, we are talking a lot about COVID virus or COVID-19, but there are other, health conditions that continue, the heart attacks and the diabetes and the renal failures and also mental health. And so we want to make sure not to forget about those individuals and to do everything that we can to be able to take care of them as well. But in closing, before we take your questions, I just thank you all for all you do. I have been at your side for many years. I know what you do. It's not easy work. And as I have said, this is not a couple weeks, unfortunately. We're looking at months. We're looking at our peak time, perhaps being in late April, early May. So we're in this for the long haul. But again, thanks for all you do, and I'll be glad to answer your questions.
Thank you, Governor Northam. Appreciate that. We have not had a mandatory stay-at-home order, and I know you alluded to that a little bit. Yet, when it's clear that some of the population is once again not taking these current requests for social distancing seriously, are we looking at any plans to do any shelter in place, et cetera?
A lot of it is, I call it semantics, but we will, and a lot of it is how we enforce it, but we will look at a stay-at-home order that I will talk about at 2 o'clock today. I think Senator Kaine can probably relate to this. We are asking Virginians to do the right thing, and most of them are, but it's like a hurricane evacuation. There may be a storm, a category 3 or 4, even 5 sitting off of our coast. And as governors say, we need to evacuate right now. There's a subset of the population that say, no, you're not going to tell me what to do. And that's what we're dealing with. So with some common sense and being practical, we want to try to get the attention of more people in Virginia. So that's why we'll expand our executive order this afternoon and also give our authorities the ability to enforce. For example, people this weekend, I've got probably 10 different pictures from the beaches. So nobody's abiding by your 10 or less order. Well, my first response was, we'll call the authorities, and they have the ability to enforce that, and they have been to a certain extent. But we need to kind of ramp up those efforts. And again, anybody that's not essential needs to stay at home until the storm passes.
All right. Thank you for that. What is Virginia's process for sourcing and distributing PPE? So it's a two-parter. Yes. The second part is, how can this process be made more transparent so that nurses can understand what materials they'll be receiving or not receiving?
Great question. And the process, we have the Virginia Department of Emergency Management, and they're working very closely with our Secretary of Health, our Secretary of Public Safety. And again, it would have been very nice to have this done at the national level that could give us some guidance for what our inventory is, where we get new supplies from, where those are dispersed to. And so we have a plan as we move forward to do that. And when we get offline, I will give you the people's contact information and kind of the process that we're moving forward with on that.
All right, thank you very much. And what plans, you alluded to this also, but are in place for handling surge capacity? Are hospitals being required to increase beds and staff? And will we be constructing any field or alternative hospital sites?
Yes, a great question. And first of all, our bed space right now, we don't think it's going to be as much of an issue as the equipment, the ventilators and the PPE. And the reason for that is because we've eliminated any elective surgeries. So that has actually freed up a lot of bed space in our hospitals. Now, we may go past that capacity, in which case we would look for alternative spaces, and we're making plans for that. Again, we're looking at the next 2 to 3 weeks. But I think what will be most challenging to nurses and staff is how we keep the staff healthy and how we have enough nurses, respiratory therapists, all the folks that go into taking care of an ICU patient. That's really what we're focused on as we move forward.
All right, thank you. What allowances and protections would the state provide if a nurse contracts COVID-19 because of their work with a COVID-19 patient? And would they cover all medical costs incurred provide a death payment to the family, etc.?
Yeah, that comes under what we call line of duty. And we actually made a lot of progress this year with our first responders and our firefighters that are exposed to different contaminants and have health issues because of what they do every day for work. I kind of agree with Senator Kaine. I don't think we've got anything in place right now, but it's certainly something that we'll look at because there are going to be healthcare providers, whether they be nurses, doctors, or whoever that may be exposed and may have long-term effects from this and their families as well. So I appreciate you bringing that up, and we will look into doing everything that we can to make sure that these individuals are cared for and their families are as well.
All right, thank you. And lastly, what criteria is being used to distribute supplies from strategic stockpiles to states, and who is getting the first priority?
Well, again, it goes back into our dispensing system that we have. You know, there are certainly hot spots in Virginia. Hampton Roads has been one of them. We've had a number of cases here in Richmond and also in Northern Virginia. And so as far as the supplies, the PPE, the ventilators, those types of things, that's where most of our energy has gone. But we also have to think of rural Virginia as well, and particularly not only with supplies, but especially with staffing, because if you think about it, if 2 or 3 nurses, for example, in a rural hospital can't come to work, that may be a large part of of our staff, and so we're looking at all of those things and making plans to take care of all of Virginia.
All right. Thank you very much. We appreciate you sharing time with us today, Governor Northam, and everything that you're doing to help during this crisis. So thank you.
And let me just thank you all again, but we will make sure that you have access to our phone numbers, our websites. We need to hear from you. We're all in this together. We're a team. And so if there are things that you need out there to care for yourself or to care for our patients, don't be shy. Please let us know what we can do to help, because that's why we're here.
Thank you very much, sir.
Yes, thank you.
All right. Now we'll be turning this over to Janine Uzel. She is the VDH Director of Public Health Nursing, and she's going to discuss the impact of COVID-19 on nurses. Janine, good morning.
Janine, I believe you may still be muted. I just sent you a request to unmute your mic, if you'll accept that.
I think we are unmuted, correct?
You are.
Okay, we'll try to share the screen again. Okay, so good afternoon. I'm Janine Uzel, the Director of Public Health Nursing, and I'm going to share a little bit with you about the COVID-19 current situation. And I'm also going to try to answer as many questions as I can that you have about testing and PPE. As you've heard over and over again, this situation is rapidly evolving. I have many emails and changes in guidance documents once or twice a day. So this is a very fluid situation. What I tell you today may be totally changed tomorrow. So make sure you're checking official websites and pages and your facility's guidance as this evolves. I want to start out with just a quick review of coronavirus disease 2019, some lessons learned so far from other countries, and a look at the global, national, and state situation. Several terms are used to describe this virus, and terminology has changed a few times. The World Health Organization has named the disease coronavirus disease 2019 or COVID-19, and the virus itself is called SARS-CoV-2. So if you think about it, SARS-CoV-2 causes COVID-19. So coronaviruses are in a large family of viruses that can infect people and many animals, including birds, bats, cattle, and camels. Animals may not show any signs of disease or may show a range of illness that can include fever, cough, runny nose, and diarrhea. Bats are recognized as important reservoirs of coronaviruses and typically do not become ill when infected. For animals, symptoms start 2 to 14 days after exposure. These viruses are spread from one to another through sneezing or close personal contact. And rarely animal coronaviruses evolve to be able to infect humans and then spread from person to person. SARS and the Middle East respiratory syndrome are examples of occasions when this jump from animals to human infection occurred and are thought to be associated with bats. The initial source of this coronavirus that causes COVID-19 appears to be bats. Human coronaviruses were first identified in the mid-1960s. 7 types are now known to infect people. Most people will get infected with at least one of the 4 common human coronaviruses in their lifetime. These viruses usually cause common cold symptoms and typically appear in the upper respiratory tract. Again, symptoms start 2 to 14 days after exposure, and the viruses are spread from an infected person to others through coughing and sneezing or close personal contact. 2 highly pathogenic coronaviruses have previously caused serious epidemics: SARS in 2002 and the Middle East Respiratory Syndrome, or MERS, in 2012. Both affected the lower respiratory tract, causing severe atypical pneumonia. Patients with MERS also have prominent gastrointestinal symptoms and often have acute kidney failure. We are still learning about this virus that causes COVID-19. So when you look at this slide, on the top row that compares COVID-19 to MERS and SARS, we see already a significantly higher number of cases. If you use these raw numbers for COVID-19 to calculate the case fatality ratio, it would be 4.3%. However, WHO estimates that the actual case fatality ratio is closer to 2.3% based on numbers not taking into account mild infections that did not require hospitalization and challenges with testing. It is also difficult to calculate the case fatality ratio in real time, as it is unknown how many of those currently ill will die or recover. The case fatality ratio is thought to be lower than for MERS or SARS. WHO estimates 2.3% based on cases as of 2/11/20, but this doesn't take into account, again, for those mild infections. It's too early to draw conclusions as to if there's real differences in the case fatality ratio inside and outside of China, because the numbers of who will recover and who will die for most cases outside China is not yet known. We are still learning about how contagious this virus may be, but it is thought to be less contagious than measles or SARS. The estimated R0, indicating how infectious a disease is 2 to 2.5, meaning that every case will infect 2 people, compared to measles, where every case infects 12 to 18 people. However, the complete clinical picture with regard to 2019 COVID is still not fully clear. WHO put out a report in collaboration with China summarizing key findings from the COVID-19 outbreak there. I want to highlight a few key points from that report. First, they saw almost 80% of confirmed cases in people 30 to 69 years of age. It is also important that China reports 80% of confirmed cases had only mild disease. Those with mild disease were recovered within about 2 weeks, versus those with severe or critical disease taking 306 weeks to recover. Case fatality rates were higher in China for those over the age of 80 and for those with certain comorbidities, especially cardiovascular disease. Routes of transmission highlighted in China were both droplet and fomite, or surfaces where the virus is present, during unprotected contact. We must, of course, remember to take higher precautions if a confirmed or suspected COVID-19 patient is undergoing an aerosol generating procedure. We did have some early reports that perhaps there was a fecal-oral route in transmission, but we still haven't determined if that's a significant route of transmission. When we look at a timeline of key events for COVID-19, we go back to the initial cluster identification in Wuhan in late December of 2019 to the first exported case in January of 2020, the declaration of a WHO public health emergency at the end of January to the declaration of a pandemic on March 11th. Here you can see all the countries currently reporting lab-confirmed cases. As you can see, impact is widespread across the globe. Here's the global epicurve by region. As you can see, the Americas represented in yellow and Europe in red, where current case numbers are continuing to rise. Countries experiencing local transmission include China, South Korea, Italy, Spain, Thailand, Indonesia, Iran, Qatar, the US, Canada, and South Africa. But that list is rapidly growing and could change and shift quickly. Looking specifically at the US, you can see some key response events highlighted in this slide leading up to the declaration of national state of emergency on March 13th. We have seen significant actions taken in Virginia in the past several weeks, including a public health emergency order going into effect on 3/17 and the governor's executive order closing schools for the remainder of the year and significantly limiting business on 3/24. People have asked about case rates in Virginia, and this is a graphic that's available on our public-facing website. We do try to update it, but we've got it reflects test numbers entered before 5 p.m. on the following day. So I pulled this last night. It won't be up to date as of today. When you look at the asterisks and the number there, it indicates positive tests among all people who are tested. Under the little tent sign, the 10,609 indicates test results received by VDH from all reporting laboratories. All negative test results may not be represented due to the large number of faxed results from new labs coming online for testing for COVID-19. Again, the numbers reflect all tests entered before 5 p.m. on the following day. The Virginia Department of Health is no longer reporting all pending test results as a large number of labs are coming online. And again, this map is available in our public-facing webpage. So we've been asked about what is currently the public health testing criteria and process. As we've said, we are short on test kits, just like many other places in the country and indeed in the world. So what we're trying to do is focus on where our testing could do the greatest amount of good. So we're really focusing right now through the state lab testing healthcare workers or first-line responders with fever or signs or symptoms of a lower respiratory illness. Potential cluster of unknown respiratory illnesses where influenza has been ruled out, because remember, influenza is still circulating, with priority for healthcare facility outbreaks. All suspected clusters or outbreaks should be reported to the local health department immediately. We're focusing on persons hospitalized with fever or signs of low respiratory illness, and priority will be given to patients where circumstances require a confirmed COVID-19 diagnosis for compassionate use treatment with antivirals. We're also targeting persons who reside or work in a congregate setting, like a homeless shelter, assisted living facility, group homes, prisons, detention centers, jails, and nursing homes, and who have a fever or signs of symptoms of lower respiratory illness, and who test negative for influenza on the initial workup. So how do we get to a test? What we have our healthcare providers doing now is entering a request for testing through the state lab into our REDCap system. We're manning it 7 days a week. We can usually get back to healthcare providers within 3 hours to let you know if your case has met or does not meet the public health testing criteria. This criteria does not apply to private labs who are coming online. So people have asked, how do we get the results from the private labs? We have a system that we work with. It's called VEDS, and it allows electronic lab reporting by lab providers in addition to our conventional means of doing what we call an EPI1 form to let us know when they have a positive result. So these can be resulted directly into our system for follow-up by our public health professionals. What specimens are we currently collecting? I know there's been a lot of talk about, the different types of testing and which testing is best. So right now our state lab, and again, that's of last night when I put these slides together, it still has to be an MP swab and 3 to 4 milliliters of viral transport media. There has been some shortage of viral transport media, but we're able to get some of that in from other sources. The shipments must be stored and refrigerated at 4 degrees Celsius and must be sent within 72 hours. If it can't be sent within 72 hours and delivered to the Division of Consolidated Lab Services, which is our state lab, within 72 hours, it has to be frozen. One of the other questions that I had is that people are being bounced around when looking for a test. What should I tell people? We know that people are calling our local health departments and not receiving the answers they want. We did stand up a state call center. The number is on your screen there. And we know that there's a great deal of frustration from healthcare providers and the public because testing is not readily available. We share your concern. The ability to perform widespread testing would help us understand how widespread COVID-19 is in our community. However, for now, we must preserve our resources for testing for the public health priority groups mentioned previously. Again, we do have a call center to help give guidance to the public. You can also, some of our health districts have set up local call centers as well. And you can visit your health department's local website, and there's a local health department, VDH health department locator tool that you can use. And I've given you the link here to see where the closest health department is to you. What's being done to increase the availability of testing? Despite all of our strategies, our capacity to test has not caught up with the demand for testing. From a scientific and public health perspective, we've had to balance the need for testing and rapidly approving test modalities with the need to assure quality testing that is accurate and reliable. As of March 24th, CDC allows for the following, although it may not be acceptable at all labs. And they're looking at allowing self or healthcare worker collected nasal swabs as an acceptable specimen type if NP swab is not possible, and allowance for self or healthcare worker collected nasal turbinate swabs as an acceptable specimen type if an NP swab is not available. We're also looking at alternative media and see if we can test swabs in a saline solution versus a viral transport media. And the FDA has removed a lot of the roadblocks and sped up the process for approving testing. But as mentioned by both Senator Kaine and our governor, we're behind in the response, particularly in terms of other countries. So what else are we doing? The Commonwealth has activated a unified command comprised of public and private agencies to respond to the pandemic. That means we are all working together in the Commonwealth to implement strategies for mitigation of community spread of the virus. This is the reason schools and businesses have closed. It's a basic public health tool that has been shown to work in the past to slow the spread of disease. Slowing the spread will provide us with the opportunity to enhance our test capability, identify and test potential treatments, and allow for the development of a vaccine. We are also trying to buy time so our medical system is not overwhelmed with critically ill cases. Many of you have asked me, do I know if we are flattening the curve? We're not sure yet. Again, we're learning from our partners around us. We're learning from New York City. We're learning from what happened in China. We'll be able to look back in a couple of weeks, maybe a couple of months, and be able to see where we missed the boat. But right now, this is what we're trying to do to mitigate the spread of this virus. One of the key public health strategies, in addition to social distancing, is contact tracing. What is contact tracing and why is it so important? People in close contact with someone who is infected with a virus, such as the COVID-19 virus, are at higher risk of becoming infected themselves and of potentially further infecting others. So closely watching these contacts after exposure to an infected person will help the contacts to get care and treatment and will prevent further transmission of the virus. Terms that we use are to isolate individuals who are ill to prevent the spread of infection and quarantine the well contact to prevent them from unknowingly. So again, this is what our public health professionals are spending a lot of time. I'm sorry, if everyone could please mute their mics, that would be great. So this is what our public health professionals are working on. For each person that is diagnosed, each number that you saw of a confirmed infection, our public health workers reach out to that individual, get lists of where they are, who they've been in contact with, work colleagues. Then we reach out to each one of those contacts to determine if they are ill, if they are not ill, to advise them on quarantine, and then it snowballs from there. Our MRC volunteers and our public health nursing staff and our epidemiologists have been working around the clock in an effort to reach all of these individuals and again, slow the spread. So what are the PPE requirements for suspected and confirmed COVID-19? And these requirements are changing rapidly. The CDC has recommendations regarding PPE for staff based on levels of risk of exposure and the availability of supplies. Remember, PPE is only one way to decrease the risk for exposure. Many of you are already minimizing entry into your facilities and screening individuals at the door for signs and symptoms of illness. Many of the precautions that you take during influenza season are applicable to this situation as well. Many long-term care facilities have halted or reduced in-person visitation and are encouraging keeping in touch through electronic means of communication. Speaking of electronic communication, think about how many times you touch your cell phone. This may be the perfect time to stash your cell phone until the end of your shift, clean it regularly, and perform hand hygiene when your shift ends before handling your cell phone. Engineering controls include erecting barriers between patients to minimize spread, such as the use of screens or curtains. Many of you have said that you're worried about the supply of PPE, and what is Virginia doing to make sure we have enough PPE? The Virginia Department of Health pushed out, through the Unified Command, pushed out its stockpile of PPE stored for pandemic influenza several weeks ago. We also request supplies from the Strategic National Stockpile, which were pushed out in conjunction with the Virginia Healthcare and Health Association, VHHA. Virginia is requesting additional supplies from the Strategic National Stockpile and is reaching out to all reputable vendors across the world in an attempt to secure additional supplies. Again, as mentioned previously, President Trump has used the Defense Production Act to increase the manufacture of PPE and other critical resources such as ventilators. But what if we run out? We know supplies are running low and your facilities and agencies statewide are working to meet the demand. The CDC has developed a burn rate calculator intended to assist facilities with estimating how quickly they are using their PPE and what their estimated needs will be. We are aware that long-term care facilities have typically had less PPE on hand than acute care facilities, and we're hearing they may be limited to ordering supplies based on previous orders from their suppliers. The tiered approach by the CDC recognizes that PPE shortages are an acute concern of healthcare providers and have issued guidance considering best case and worst case scenarios. We are emphasizing the use of droplet precautions to maximize the use of PPE. So when you look at the strategies that the CDC talks about, they talk about conventional capacity, which means we're open doing day-to-day business. We have plenty of PPE on hand. Contingency capacity, which means we may have to change our day-to-day operations. And crisis capacities. And that's when we implement crisis capacities, we're starting to implement strategies that are not commensurate with U.S. standards of care. And these may need to be considered as PPE shortages grow critical. So what does this mean for you? You may be asked to reuse PPE or use PPE that can be clean. They are working on several ways to use either UV light to clean PPE. Guidance is coming out how to reuse the same N95 respirator and eye shield or goggles when assessing all your COVID-19 patients. We've already implemented that the PPE can be used beyond the manufacturer's use-by date. We're asking people to undergo just-in-time respirator fit testing instead of annual testing, and also asking people to assess the risk of your patient care encounter and adjust the use of your PPE. In other words, using a face mask possibly versus an N95 respirator based on the risk of exposure for your particular task. Your employer will be providing guidance as this situation evolves, and please follow their guidelines. I understand the need to reuse face shields after cleaning, but what about gowns? You may be asked to use coveralls. Those are the sort of white Tyvek suits that you see, and we saw them used in Ebola response. You may be asked to reuse gowns, particularly when you've got clients that are cohorted for COVID-19. Again, the same with other PPE, isolation gowns may be used beyond the manufacturer's use-by date. Alternatives such as the use of cloth gowns may be considered, and alternatives when no gowns are available may be considered, including lab coats or other alternatives. There is the guidance here at the CDC website, and again, please follow your facility's alternate plans. The shortage of N95 respirators and masks is our major concern. What are the plans if we run out? Limited reuse, as I've talked about, when caring for patients with COVID-19 may become necessary. However, it is unknown what the potential contribution of contact transmission is for SARS-CoV-2, and caution should be used. Reuse should be implemented according to CDC guidelines. Reuse has been recommended as an option for conserving respirators during previous respiratory pathogen outbreaks and pandemics. It may be necessary to reuse N95 respirators when caring for patients with varicella or measles, although contact transmission poses a risk to healthcare practitioners who implement this practice. This is a chart by the CDC, and it's on the previously mentioned website that provides information for maximizing the use of respirators based on the proximity of the healthcare provider to the client, and whether the client is masked or unmasked and what you'll be doing. So again, we're trying to recognize the need for PPE, but understand it's limited, and where we can use less PPE where it's safe so that we can preserve what we do have. Another question I've received is we see that sewing groups are producing masks for healthcare providers. Can we use these masks? At this time, the CDC is recommending the use of masks not evaluated or approved by NIOT or homemade masks as a last resort. However, we find it heartening that the public is concerned about healthcare worker safety and is committed to providing as much assistance as they can. As a note, wearing masks by healthy individuals is not currently recommended nor endorsed by the CDC. Adherence to these recommendations should increase the availability of resources for healthcare providers. Environmental cleaning is a critical component of preventing and managing cases. This should include cleaning and disinfection of frequently touched surfaces and objects several times a day, cleaning of shared equipment, adherence to product recommendations for contact time. Facilities may want to consider increasing the number of staff trained and responsible for cleaning common areas to increase cleaning and disinfection intensity and frequency. I'm a healthcare worker and I have been exposed to COVID-19. How long do I need to quarantine myself? Again, check with your occupational health center for guidance, as this guidance is literally changing as we learn more about this virus, how long between exposure and how long and transmission and how long the incubation period is. We also know that nurses are the key to keeping our healthcare facilities up and running nationwide. Again, guidance from the CDC is changing rapidly as the situation evolves. We are seeing facilities with outbreaks going to surge staffing and saying healthcare professionals should work even if exposed while asymptomatic. I'm a nurse who has been diagnosed with COVID-19 infection. How long should I stay out of work? Again, contact your occupational health department for guidance. Currently, as of today or last night when I did this PowerPoint, generally with testing, you need to be fever-free without medication for 72 hours and symptoms of improved and 2 negative tests collected 24 hours apart. Without testing, fever-free without medication for 72 hours and symptoms have improved and at least 7 days have passed since the first symptoms appeared. For those who never showed symptoms but had a positive test, at least 7 days must have passed since the first positive test and no new symptoms have developed. Again, this guidance is changing rapidly and I urge you to keep in close contact with your occupational health setting. As nurses, you are the nation's most trusted professionals. Your communities rely on you to provide accurate, knowledgeable health care. Please share with your communities the importance of social distancing, symptoms of COVID-19 and those who are most at risk, and the importance of hand washing and respiratory etiquette to slow the spread of COVID-19. Please know that we are doing all we can in the Commonwealth to slow the spread of COVID-19 and ensure the protection of our healthcare providers against this pathogen. Thank you all for everything that you're doing in your communities. Your service and dedication is truly appreciated.
Linda, I think you're muted. Hold on just a moment.
All right. Ms. Giselle, thank you very, very much for that great overview of the information. We appreciate it very, very much. Have a few questions, and then I'm going to turn it over to Lindsay Caldwell, as she has some questions too. But relative to how many Virginia residents have been tested for COVID-19, and do these results include the private labs? If not, how accurate a count do we think we have?
So the slide that I put up there shows you how many that have been tested from our standpoint. But when you look at what the private labs report, often it's just the positive results. So private labs are probably testing more, but the way our electronic lab reports work is it sends over what we call the abnormals, or the ones that are positive. We're getting them to fax us numbers, but with more and more coming online, such as the lab in Fairfax, UVA, LabCorp, Quest, we may not be seeing all the testing that's being done. We may just be getting more of the positive results.
All right. And really, what is the current testing criteria? I know it's changed over time, so can you update us?
So I did go over that in my slides. Again, we've had to prioritize who we test just because we just don't have enough test kits. So again, it's those 4 groups. It's healthcare providers and first responders with fever or respiratory symptoms of a lower respiratory illness, potential clusters of unknown respiratory illness where influenza has been ruled out with priority for healthcare facility outbreaks. And as a reminder, please report all clusters in your facilities. And then persons hospitalized with fever or symptoms of lower respiratory illness, and we're giving priority to those that may need compassionate care, treatment with antivirals, and people who live in congregate living settings. So that's for testing through the state lab. Those constraints don't apply to our private labs.
Thank you, Ms. Uzel. All right, I'm going to turn it over to Lindsay.
All right, thanks so much, Linda. We have a few questions and we do realize we're running over, but we wanted to ask some of these because we know that they are very important. So I just want to go through a few of them with you. Okay, so the first one, and if you could speak to what is the sensitivity and specificity of the standard COVID-19 test?
Well, I'm the first to admit that I'm a nursing specialist and not a lab specialist. So I don't know that I can answer that question for you. I'll try to find out from Denise Toney, who's the director of Consolidated Lab. But I think that's one of the issues with bringing testing online that I alluded to, is that we want to push tests out. We want to remove some of those barriers, but we don't want to put kits out there just to put tests out there. We need to make sure that they are accurate and reliable, just like your Channel 12 meteorologist. Accurate and reliable weather, accurate and reliable testing, and that's what we're really going for.
Thank you. Can you tell us, is the position of VDH that if a person tests positive for the flu, that they will not test for COVID-19? And is it conceivable that these two may exist, producing a synergistic disease?
Yes, so we are seeing co-infection with influenza and COVID-19. And as we're learning more about that, our guidance may change. Of course, we were going by flu because flu was still widely circulating. It's calmed down a little bit nationwide to be able to actually treat folks with flu who are at high risk with antivirals. We know that would work. We're not 100% sure what's going to work for COVID-19. So yes, we are seeing co-infection with both. But as of now, our guidelines are what our guidelines are.
Thank you. We do have a few other questions specific to PPE, as you can imagine. And so some of this may be repetitive for you, but I think it's important to have some clarification around it. So one question that we had pop up was, are they reading the slides correctly to say that an N95 is not always required for healthcare workers in close contact with patients known to have COVID-19? Are there times when they would wear just a face mask? And so I know you spoke to some of the guidelines around that, but if you wouldn't mind just reiterating that, Mrs. Uzel.
So again, you've got to follow your healthcare facilities guidelines. And what the CDC is looking at is how can we safely provide care and preserve as much of the PPE guidance that we have. When you're looking at those interactions where you're more than 6 feet from the individual, you're taking a history, talking to the individual. We're really thinking more droplet precautions. So can you go to a face mask if you're within 3 feet, providing routine care such as vital signs, and it's a non-aerosolizing procedure? These guidance are looking at, are you in a critical state? Are you in a contingent state? Or do we have enough PPE to take all the precautions possible and work at that highest level? So again, it's looking at where your facility is and following that guidance, and the CDC doing the best that they can to identify, all right, if we don't have X, what would be acceptable for Y? And those are some of the guidance that you'll see on the CDC website. Again, we can only say this is what the science tells us. your facility knows what situation they're in and are going to be making recommendations for the facility. I know there's been a lot of questions about cloth masks. Again, unless it's the absolute last resort, CDC does not recommend that healthcare providers use those.
And can you speak in regards to the cloth mask as to whether it's appropriate for us to use those on patients? I know that has come up as a question.
That has come up as a question here too, and we're still trying to figure that one out from the scientists. So, you know, one of the guidelines for patients are if you run out of masks for patients, for them to use tissues or other items for respiratory etiquette. Whether we'll be using cloth masks on patients, not as of today, as of this hour. But I know the question is being asked at the CDC level.
Okay. And this question may be more difficult to answer as well, but if facilities still have nursing students within their organization, obviously we would want them to follow the same guidelines, but do you have any guidance from VDH in regards to nursing students or other students within the facilities?
So if nursing students, you know, it's our recommendation if they're providing bedside care that they have the same precautions as the nurses that they're working with. But again, this is a changing situation. But that is the recommendation, that students follow the same precautions as regular healthcare providers because they're providing healthcare at the bedside.
Great. Well, I know that we're about 15 minutes over. So the last question I had for you was, many participants have asked if they could have a PDF of your slides. And I don't know if that's something that we can share, but we thought we would ask while we're on here so we can just let them know if that's a possibility.
I do have to go through my channels, but I'll see what I can do to make that happen. I guess the words printed under were my speaker notes, so it probably doesn't give you the full guidance, but I'll see if we can get these slides and get them as a PDF to you.
Thank you. We appreciate that. Linda, I'll turn it back over to you.
Well, great information once again, and we appreciate you taking time out of your busy schedule to be with us today. In closing, I just wanted to thank our guest speakers for being with us today and the work they're doing to address the issues and concerns around COVID-19, particularly in relation to our frontline nurses, healthcare partners, and Virginians. For our nursing colleagues, the Year of the Nurse has taken on a new meaning. Over a year ago, when the World Health Organization, along with the American Nurses Association, deemed 2020 the Year of the Nurse and Midwife, no one could have fathomed what lied ahead. Celebrations now take back seats to creativity and ongoing uncertainty, which now is part of our daily lives. Essentially, life as we know it has changed as new norms evolve for us on a daily basis, norms that can impact us far into the future. Therefore, a thank you almost seems insufficient given the challenging work and sacrifices you are facing on a daily basis. Please know, on behalf of myself, the VNA board, Janet Wall, our CEO, and the staff of the VNA, we are deeply grateful for your tireless and courageous efforts in caring for our communities, colleagues, friends, and family throughout the Commonwealth. Those that have succumbed to this virus and are requiring our most intimate skills and abilities to help navigate them through. Regardless of one's work setting, we are all in this together, doing our best and utmost to stand strong and do those things that nurses do every day, and that is putting our patients first. As a reminder, we will post the recordings of this call on our COVID-19 page at virginianurses.com and can also check it out on our Facebook page for information on upcoming events. Thank you for joining us today, and may God bless you and keep you safe. Thank you.